You tell me.
That was gastrointestinal. Okay. All right. Talking to myself. Gastrointestinal, yes. We talked about gastrointestinal, and then we talked about cerebrovascular. Okay. So, looking at these three different organ systems, we said that when we receive radiation dose, the first type of syndrome we're going to be seeing is hematopoietic syndrome because that's the lowest threshold. Right? So if there's low doses of radiation, we're most likely going to see hematopoietic. Hematopoietic, hemato being blood, poietic meaning formation of. So this is about the formation of blood, right? Production of blood. And so it's not about the existing blood cells, right? The red blood cells, white blood cells, platelets. It's about creating new blood cells. And so, like we discussed last chapter, right? White blood cells, they have very short lifespans. So those are the ones we constantly need to be created. Hematopoietic syndrome then means that our white blood cell counts will drastically decrease because we're not constantly refreshing them anymore due to radiation damage. Like gastrointestinal syndrome happens at slightly higher doses, right? So hematopoietic was about 1 to 10 gray. Gastrointestinal, we're looking at like 6 to 10 gray. So this is going to be dealing with the intestines, especially the epithelial cells lining the GI tract. And then finally, we have cerebrovascular, which we said happens at really high doses, right? 50 grays and above. Okay, and so that's going to affect nervous tissue, brain, heart, vessels, right? The cerebral system and the vascular system. Yes, Shahid.
These three syndromes are reactions to radiation.
Yes, these are short-term reactions to radiation. Everything we're talking about is a short-term reaction to radiation. We went back over lethal dose. Okay, so should be familiar from what we discussed last chapter. We also went back over the oxygen effect. And then we ended here with tissue damage terminology. So I said that do make sure you know words such as atrophy, radiodermatitis, erythema, desquamation, appellation, alopecia, mutations, aberrations. Right, especially these aberrations we discussed last chapter as well. Speaking of terms, that reminds me, you guys have terms due today, don't you?
You got it.
Yeah, you guys do, don't you?
I was not saying no. I think we do.
Okay, so if you want, please just take your vocab, pass it toward the center so I can pick it up.
Oh, I couldn't find basement membrane.
Basement membrane.
Okay, here we go.
We'll discuss this as well.
Here it is. Is this it?
This term should be missing one term.
Thank you,
Turn it
Taylor.
in there.
Did you already get it?
That ain't you got so much stress in your head.
Here's your.
You didn't even know what your homework.
Gracias.
This is chapter 8. Thank you. Good to do? Yep.
All right, anyone else have vocab that needs to be turned in? Anyone else have vocab that needs to be turned in?
That looks like that's everybody.
Wait, look at the back.
Okay, in that case,
Never mind.
do we have any questions over what we discussed on Tuesday?
Yes.
Yes.
I don't even remember what we discussed on Tuesday. I'm sorry. So,
Okay, well, we just
we
went
talked
back
about
over.
effects. No, we talked about gastro. Yes. But there was an effect, the hemo.
Hematopoietic.
That was the one that's like 1, right?
What do you mean by
That
what?
occurs at like 1 grade.
1 to 10 grade, yes.
Okay, 1 to 10 grade. But the lowest is 1, the highest is 10.
So, really, I mean, you're going to see hematopoietic syndrome even beyond 10 grade, but
Okay.
just most commonly when a patient receives somewhere between 1 to 10 grade,
Okay.
that's when we'll see it pop up in them.
Okay, so then the next one would have been the
Gastrointestinal.
Okay, and that occurs at
6 to 10 grade,
6 to 10 grade, and then the last one would have been,
cerebrovascular,
and that occurs at
50 and above.
50 and above, okay. And those are terms right there. So we did talk about the linear threshold and the non-linear threshold, right?
We did.
Okay, so linear non-threshold is in from that point up.
Good. So,
And
yes.
linear threshold can be at any point on the line, straight.
Mhm.
Okay, and then non-linear threshold is curved, but from that point, the center point of the line, like.
Say
in
that,
the-
say
right.
that again?
Non-linear threshold, non-threshold is from that point in the middle and then
Yes.
curved.
Correct.
And then non-linear threshold is from any point on the line but curved.
Yes.
Correct. Okay, and we talked about,
Of those four, which one best describes our short-term reactions?
non-linear, non-threshold.
Non-linear, non-threshold?
That was a guess.
Was a guess?
Yes.
So, once again, for hematopoietic, when did we first start seeing it?
Between 1 to 10 grade.
Do we see it at 0.5 grays?
No.
0.2 grays?
No.
0.1 grays?
No.
So what is that 1 gray?
Oh,
axis?
so it's threshold, it's linear.
So-
It's linear. Linear, non-threshold.
So the limit, right, the fact that we need at least 1 gray before we see it makes it
Right.
threshold.
Okay, so.
Right, the 1 gray
linear
axis of threshold.
Okay, so non-threshold means anything less than 1?
So non-threshold means any dose causes a reaction.
Oh, okay, so it can be anything less than 1 to 10. I'm just using an example, like 0.1, 0.2, 0.2,
So
4, 5, 6, 7.
non-threshold means that as soon as you leave 0,
Okay.
something
Oh,
happens.
got it,
right?
got it. So then that would be
There's no
non-linear threshold.
So, correct.
Right?
So short-term effects are non-linear threshold.
Okay. And we talked about deterministic effects, right?
So yes, our tissue reactions, hematopoietic, gastrointestinal, cerebrovascular, are deterministic, what we now call tissue reactions.
Okay. Let's see. Like, cataracts? Would that be an example?
That's long-term. That would be for
That's
next
long-term?
chapter.
Okay, so like, come on, somebody help me out here.
What are we looking for?
Lisa.
Oh, that. Thank you, Cody. Oh, like atrophy,
Mhm.
the shrinkage of organs, or radiodermatitis,
Mhm.
the reddening of skin, or desquamation,
Mhm.
shedding of the outer layer of the skin,
Yes.
percolation.
So these are our short-term effects that are non-linear threshold.
Okay, so, and we talked about stochastic also, right?
So we have not discussed stochastic.
Okay.
Everything so far has been a tissue
Just
reaction.
making sure, just making sure. Anybody else have any questions?
So tissue reactions doesn't come in stochastic.
We said
Doesn't
tissue
cover
reactions
the
are a
review, right?
synonym for what?
Determined.
Tissue reactions are a synonym for what term? Deterministic. Deterministic is a synonym for what term?
That is not stochastic.
Non-stochastic. So are tissue reactions stochastic?
As if they are stochastic.
No.
Like I said, tissue reactions are deterministic. Deterministic is
Non-stochastic.
non-stochastic. Can something that is non-stochastic be stochastic?
No.
So are tissue
Tissue
reactions
reactions.
stochastic?
No.
They are not stochastic, correct?
They're determined.
They are deterministic.
Thank you for the review.
You're welcome. Okay, so now that we've gone over Tuesday twice now, we are all very comfortable with the material, correct?
No.
Yep, let's
No.
do it.
Don't worry, I don't have a
Since,
pop quiz.
since I was
We're just
thinking that's
moving
what you
on.
were gonna do.
We're just moving on here. So, okay, a lot of the things that we saw here, right, deal with the skin.
Yes.
And that makes sense because the skin is the first thing that radiation is going to hit. Okay? Skin is also made of cells that are rapidly dividing, right? We're constantly shedding skin and growing new skin. So the skin is going to be heavily affected by radiation. So let's take a quick look at the anatomy of the skin. For the skin, we have the epidermis, which is the outer layer, the dermis, which is the middle layer, and then the hypodermis, which is the inner layer. I remember this because in an old Bill Nye episode, he'd like to joke about how your epidermis is showing. Okay. I don't know why I remember that from Bill Nye, but that's what it is. So, epidermis, outer layer.
Somebody watch Bill Nye the Science Guy.
Bill.
Yeah, that's the only things I was allowed to watch as a kid when I came home from school was Bill Nye, Sesame Street, and Mr. Rogers. And Wishbone.
Wishbone was the best.
Yeah, I love Wishbone.
That's all you can watch?
That's all I can watch.
Oh, no.
Yeah, everyone's talking about Dragon Ball Z. I'm like, what's that?
HBO
No.
Power Rangers. Is that something you can drink?
Ooh.
Oh no, that's Powerade? Okay, never mind.
Oh, so you watch PBS
Yes.
all day, pretty much. 'Cause
I mean, it wasn't
Bill
all day.
Nye came on in the
It was a
evening.
2-hour block.
I know, but it came on in the evening, Bill Nye.
Saturday.
Mm-hmm.
Yeah.
Okay, anyway, that's enough about my sad childhood. Back to skin. So epidermis, dermis, and hypodermis. Okay, so these are the 3 layers of the skin from outside to inside. Note that here, between the epidermis and the dermis, we have something called the basement membrane. Okay, so this is our basement membrane. This is where most of our stem cells are going to be.
So it's like the bottom layer of the skin, the bottom layer.
In addition, we've also got other parts of the skin, right? You've got sweat glands, you've got hair, right? You've got sensory cells. Oh, what are sebaceous glands?
Sweat glands.
Yes, sir.
Or
Right,
oil.
oil glands.
Yeah.
Yes,
That's where you get pimples.
that's where you get pimples. Yes, if they get clogged up. Okay, so skin is constantly regenerating, right? Our skin cells, once again, located in the basal layer, which is basement membrane. And because they're constantly regenerating, right? That law of Burgundy and Treppendow. Rapid division means more radiosensitive. Okay. So stem cells undifferentiated, stem cells divide often, makes them more sensitive. Okay, so I'm gonna go ahead and give a warning. We are gonna take a look at some pictures of radiation damage. They're not that gross looking, but we just all had lunch, so I'm giving you time to mentally prepare yourselves.
Hope we didn't have chili.
So the first thing we're gonna look at is radiodermatitis. So it's just gonna look like a bad sunburn here. Okay, radiodermatitis.
Mr. Donahue looks like that sometimes.
Oh.
Shots, James, shots.
Hey,
That's not a shot. I missed him there.
Hey, Mr. Donahue, you know what Jay just said about me?
Yeah, I miss you, dude. Like,
We don't want Mr. Phung. Don't that
He's
work
gonna
for
come
you?
back with a like. He's gonna come back with a 1-to-1 scale replica of Andero, Flame of the West.
You can't come back.
It's a Lord of the Rings joke.
okay, I was like,
Thank you, Charlie. Thank you. I appreciate it. Anyway, moving on. Okay, so radiodermatitis usually threshold of around 2 gray. Okay, so it takes about 2 gray for this to start showing up. Usually appears within 28 to 48 hours of exposure. Okay. And then it just gets worse over a period of 1 to 2 weeks.
Yeah.
So there we have it. Okay, next up, we have desquamation.
We have a
Yes,
question.
Cody.
So in the 1 to 2 weeks, it's just gonna keep getting worse?
Yeah, so it'll get redder and redder.
Really? Oh,
Yes.
okay.
And maybe even black, perhaps.
Like, that's
just
not-
depending on
Whoa,
cell
whoa,
damage.
whoa, whoa.
That's not because they're like being exposed to more, right? It's just they've been exposed to that much and their body just keeps just making more
Mhm.
damage, I guess.
Right.
The
Right,
breakdown
so-
of the DNA.
Thank you. Right, so for example, last chapter we talked about different types of cell death, right? We have instant cell death, which definitely not in this range, right? But then we have things like reproductive cell death, mitotic cell death, right? And so it can take a while for the cells to start dying off,
Mhm.
or for the damage to really start showing up.
Mm, okay.
Okay, next up, desquamation. So remember, desquamation we said was the shedding of the skin. Right, so as you can see here, we have now lost some skin, right? The epidermis layer has shed off. Okay, occurs at higher doses than radiodermatitis, so
That just looks like a good watercolor.
if only it was just watercolor paint. Okay, so the book didn't give an exact threshold dose, but it's higher than 2 gray. Okay, first appears as moist or wet desquamation, right? So the skin is wet as well as peeling off, and then later the wetness goes away and it's just dry desquamation. The book also did not have a time range on this one. Okay, next up we have epilation. So this one is pretty famous. It is just loss of hair from radiation exposure. So epilation, hair loss. Okay. Moderate doses causes temporary hair loss. High doses can cause permanent hair loss.
Oh, so that's why when you have chemotherapy, you lose your hair.
Right, so chemo and radiation therapy,
Yeah.
right? Radiation therapy can kill off those stem cells. And so without stem cells,
Your hair goes.
that's right, no more hair.
Falls it normally comes back, so they don't do it to that dose, that doesn't come back.
What is that, Shaheen?
Sir, I've seen very close patients, they get rid of all the hair, it falls off,
Yep.
but it comes back all the time, it's never in the second stage.
So that would be moderate.
It's always moderate.
Moderate doses, yes.
Oh,
Right, so only temporary hair loss. It can come back afterwards.
so they might,
Keep it ready.
if they give high doses, they might not come back.
Correct.
You got permanent hair.
So over here, this is a picture of a survivor of one of the Nagasaki atomic bombing. Right, that was the second bomb that was dropped on Japan during World War II.
But does that have to do something with chemo?
Little boy.
Because chemo patients will also.
Chemo patients also lose their hair. So it all just goes back to the fact that both chemo and radiation therapy, their whole purpose is to kill cancer cells. But the radiation and the chemicals aren't super specific. You can't target only cancer cells.
So you have to target all the cells.
So yes, one of the side effects is that if it hits other cells, right, collateral damage, right?
So that's
So-
why they tell you about those sides.
Stem cells for hair, this can happen as well.
We'll
You
save
also
your
get
life,
like the
but
previous
you
one, like
won't.
erythema and everything.
Desquamation, desquamation I think is going to be a
Implants,
more
though.
radiation
Things-
specific effect.
Okay.
I haven't heard of desquamation happening from
Implants.
chemo.
I can talk about it.
So, nowadays, where do we see most of these effects coming from? Right, we aren't really dropping atomic bombs on people willy-nilly anymore. Right? This is in the 50s where we had
Nuclear
atomic testing
medication.
in the air. So, yes, Jay.
Cancer patients or people that work or live around high levels of radon.
Okay, so places with naturally high radiation. Would that be? But even though those are high levels of radiation, would that be enough
No.
to cause these effects?
No,
Because these thresholds are relatively high for
no.
like natural causes. You would need to be somewhere that you would not be able to stay very long, or else you'd actually just kill yourself.
So on that, in Houston, there's an area that has 50 times the amount of daily dose for public exposure, and people were living there before they realized it. So I would argue that that's environmental.
Okay, it's possible. Okay, all right. Not a, I guess, particularly common occurrence, but it is a possibility. Yes. But more commonly, where do we see this?
Sun rays.
Well, it's usually man-made radiation,
Mhm.
and usually from diagnostic, right, or medical radiation. So radiation therapy and high-level fluoroscopy. Okay, so radiation therapy, of course, really high doses of radiation because we're trying to hit those threshold doses needed to kill cancer cells. And then high-level fluoro, right? Fluoro just using high technique over a long period of time will also give a lot of dose. Okay, so, with radiation therapy, how do we target cancer cells without killing off all the healthy cells? Well, we go back to two concepts. we go back to the idea of fractionation. What did we say fractionation was again?
Giving part by part.
Right, giving doses bit by bit by bit. Rather than a single dose all at one time, we take the dose and spread it out. It gives the body a chance to recover in between doses. But if the body's recovering, so will the cancer. So what else do? We target the cancer from multiple angles.
Oh, radiation therapy does that.
Radiation therapy, that's right. So we target the cancer from multiple angles that way. We're not taking all of our dose and putting it through healthy tissue
Right,
all
for the entire body.
together. Right? We're gonna take our dose, split into 5 pieces, and here, right,
Yep, shoot.
each of these pieces of anatomy only get 20% of the total dose. But the cancer, which is in the middle, will get all 100% of the total dose. So this is where we'll be really killing the cells.
That's why they have to be so precise.
That's right, that's why you have to be so precise. If you've been through radiation therapy, you may have seen that they have those masks
Yep.
that they give the patients.
Yeah.
And then they put like the dots and they have to
And
center
they make them,
perfectly.
they make those specifically for them.
That's right, those are actually tailor-made for each patient.
Mhm.
Okay.
To prevent
So-
leakage, like into the patient.
No, it's just to prevent you from blasting the wrong area of
From
the
blasting
patient.
the wrong area, so you can shoot directly, so they put the points on the mask from a measurement they get in the, when they do the CT one, what is it called again? When they first measure them for the mask, when they go in, the simulation. And then they have to use that every single treatment, so that they have a ceiling, right? They can't go past that, they have to be within that certain range, yeah. Which is why I like radiation therapy, because
So-
it's very precise, numbers are my thing, I like the numbers.
So is the mask like a MRI coil? It can go anywhere, not just like face mask?
No, it's a face mask, it depends on where
Depends on
the
the
tumor
area.
is, you can
Yeah.
have a chest one.
Yeah,
you
so
have
it's
a
like an
face one.
MRI coil. Kind of.
Okay, so yes.
It's the
Similar,
mesh.
yeah,
Okay.
kind of, but not exactly.
No, it's like mesh.
Yeah, it's a different, yeah, so it's like,
Okay,
like
sorry.
a scarf.
Alright, so we're gonna
Yeah,
cut the
go.
conversation off. Definitely some fun conversation we can have in between classes, but
Yeah.
well, let's keep going here. Okay, so we don't need to know it in that much detail, right? But as far as radiation therapy, how do we keep ourselves from killing healthy tissues? 1, fractionation. 2, having multiple entry locations. High level fluoro. Okay, these can have very high doses, right? 100 to 200 milligrams per minute. That means within 5 minutes, 5 to 10 minutes, we can hit 1 gray. Right? So, high level fluoro, we do have strict controls on usage. We also need to be very careful with how we use it. Okay? And of course, with all fluoro, right, we always need to make sure to have our dose report. Okay, so moving away from the skin, we can talk about the reproductive system again. So this is just a review, basically, of previous chapter. Right? Once again, we said germ cells relatively radiosensitive. Even small doses can depress the population of the germ cells. And then doses to the germ cells can also cause genetic mutations. And if the germ cells have mutations, then those mutations can be passed on to the future generations. So, just as a reminder, germ cells, this is the sperm. Okay. Takes about 3 to 5 weeks to produce new sperm, so that's why it's recommended that after exposure to the testes, right, wait a month for the sperm to kind of cycle out and for new sperm to be formed. Okay, this slide exactly the same as last time. Okay. Nothing new here. And then on the female side, right, we have egg cells. Okay. Scientifically, are oogonia, ovum for the fertilizable egg cells. Okay. Females only produce about 400 to 500 mature ova over their lifespan. Okay. So much more limited compared to sperm cells. Okay, once again, exact same slide as last chapter. Okay, so point 1, right? Recommend waiting for 1 period cycle to expel the egg. New egg comes in, right? 2 grays temporary, 5 grays permanent sterility. Okay, hematologic effects. So, dealing with the blood. We kind of already discussed this with hematopoietic effects. Okay, but as far as hematologic effects, right? So dealing with our bone marrow, circulating blood, our lymphoid organs. Right? Remember, we have stem cells to produce all of these blood cells. Okay? These stem cells we call pluripotential because they have many potentials, right? Plural potentials to grow into all sorts of blood cells, right? They can be red blood cells, white blood cells. They can be platelets. Like the road is your oyster. You can be anything you want to be when you grow up. Okay. So, what happens when these stem cells die off? Right, hematopoietic syndrome, right? These stem cells die off, and now we lose our blood cells. If we have a reduction in red blood cells, that's anemia. But once again, remember, this is the least common effect of the hematopoietic syndrome. More commonly, reduction in white blood cells, so infection, that's what's going to happen. Reduction in platelets, bleeding, right? Hemorrhage, bleeding, that's what's going to happen. And then just remember, diagnostic imaging, right? X-rays, negligible damage to the hematopoietic syndrome or system. Right? So X-rays do not give enough dose to really damage our blood-producing cells. Yes.
Just how much difference between hematopoietic and hematologic effect? So that's it. Hematopoietic is a condition and hematologic effect is a.
So hematopoietic is specifically about production of the blood cells. Hematologic then is going to be about the blood cell. Right, so we're not talking about the formation of blood cells here. We're saying if we are missing these blood cells, what's going to happen? Okay, and finally, we have cytogenetic effects. Cyto being a prefix that means cell. Right? So cyto is cell, genetic is genetic, deals with genes. Right? So cytogenetic, these are the genetic or gene effects on cells, right? Just dealing with the chromosomes of the cells, the DNA of the cells. So here we actually see physical pictures of the chromosomes. Right? This isn't like pictures that they drew. This is not an illustration. These are actual pictures of the chromosomes. Okay? And you're able to actually see the chromosomes and take pictures of them during, anyone remember which phase of cell division?
Metaphase.
Metaphase. That's right. During metaphase, you can physically see the chromosomes. You can take pictures of them, and then you just kind of match them up. You had another question, Jay? No, I thought I saw your hand.
No, I was scratching my head. Sorry.
Okay. All right. So here we basically paired up our chromosomes. We made a map so we can physically look at our chromosomes. And so this kind of picture is called a karyotype. So we have a picture of the chromosomes during metaphase. Okay. We take our chromosomes, match them together, and we usually arrange our chromosomes in order of big to small, right? These are our biggest chromosomes. As you can see, they get smaller. So that's how we have numbered our chromosomes. And so you can actually, visually, physically see whether or not the chromosomes have been damaged. You can see if there are breaks or if one chromosome is shorter than the other. So that is the usefulness of a karyotype. So once again, by observing the karyotype, visible damage to the chromosomes can be observed. So we can see chromosome aberrations or chromatid aberrations with our own eyes just by looking at a karyotype. Of course, as the dose of radiation within a given time period increases, the rate of production of aberrations also increases, right? It's more likely we get these aberrations as the dose goes up. Now, since we are talking about X-ray, they've done studies on this with X-rays. We have not shown that X-rays in a diagnostic setting cause chromosome aberrations. We have not been able to link the creation of chromosome aberrations with diagnostic X-ray procedures. So as far as we are concerned, as long as we stay within normal technical factors, right, normal procedures, normal protocols, X-rays will not cause cytogenetic effects. There's no noticeable difference in the production of mutations from X-rays. Okay, so hopefully that'll put your hearts and minds at ease. Yes, Nancy.
The slide 34 for the
Mhm.
hematologic effect, up at the bottom it says
Mm.
chromosomal changes have been observed.
Chromosomal changes in lymphocytes have been observed. That's a great question. You'd have to probably have to reference the book to see exactly what they were referring to here. It does seem kind of contradictory, doesn't it? Chromosome aberrations, chromosomal changes. I wonder if it's some sort of change without being an aberration. That's a good question. On the bright side, since these are lymphocytes, even if something did happen to the lymphocytes, they die off after like 5 days, and then everyone's happy again.
Isn't it just mitotic delay?
Could be mitotic delay.
Okay.
Well, although lymphocytes really wouldn't be going through mitosis in the first place.
Then how do they oh, they're specialized, my bad.
So stem cells would be the ones doing it.
Listen.
All right. So one thing I do want to point out as far as cytogenetic effects are concerned, up until this point, pretty much everything we've talked about, we've said has been our threshold, right? Our nonlinear threshold, because these have all been somatic effects, right? You need at least this much dose for this to happen to this body part or this organ system. But with cytogenetic effects, with genetic effects are stochastic. These are not tissue reactions. So genetic effects are stochastic, which means they are linear, non-threshold. Okay, so I did not put that in here, but make sure that you know stochastic effects are linear, non-threshold. As soon as there's any radiation, there's a chance for these effects to occur. The more radiation you have, the chance of these increases. Okay, so the more radiation there is, the chance of aberrations will increase. Okay. You can't guarantee an aberration, but your chances will eventually get really, really high with really, really high doses. Okay. It's not like everyone who is exposed to 2 grays will always have aberrations, right? That's not how it works. It's just a chance.
So it's linear, non-threshold.
Linear, non-threshold.
You said generic?
Genetic effects.
I wrote down here stochastic effects are linear, non-threshold. I wrote it wrong, sir.
No, that is correct.
Also, genetic effects are linear, non-threshold.
Stochastic. So genetic effects are stochastic. They fall under the category of stochastic. They are random. All right. And that's actually the end of the slide. We are done with the chapter. So, how do we feel?
We feeling.
Feeling. So,
Yeah.
you got your tumbler right there. You got a
feel
sippy
like
straw on
that's
that one?
a lot of information that we all have to take in with the rest of this stuff. That's
Now,
good.
to be fair, one is only 36 slides.
Samantha.
Yeah.
2 of those 36